Good afternoon, everyone, and welcome to this webinar entitled 7 Common Misconceptions of Obsessive-Compulsive Disorder. We're so delighted you can join us for this OMH-sponsored educational activity. My name is Sapana Patel, and I'm an assistant professor of psychology in the Department of Psychiatry and the Director of Strategic Planning at the Center for Practice Innovation. I'd like to introduce my co-host and colleague, Dr. Blair Simpson. Dr. Simpson is an internationally recognized expert in OCD. She is professor of psychiatry at Columbia University Medical Center and the director for obsessive-compulsive and related disorders. Dr. Simpson's research program focuses on how to improve treatments for people with OCD so that these people can live productive lives. Her research is interdisciplinary. It ranges from treatment development studies to clinical trials examining the effects of medication and cognitive behavioral therapy to brain imaging studies exploring the brain mechanisms of OCD. I'm so delighted to be co-hosting this webinar with you, Blair, and I'll now turn it over to you.
Hi, thanks so much, Sapana, and thank you to everyone who's listening. So our goal today is to help you learn about OCD and its symptoms, to understand a little bit about the causes of OCD, and to learn a little bit about treatments for OCD. And how we're going to do this is I'm going to outline 7 common misconceptions about OCD and then tell you what the data really show. So let's start with the first one. The first one is OCD is rare. Well, let me show you the facts. In fact, the lifetime prevalence of OCD is 2%. That means 2 in 100 Americans will have OCD in their lifetime. What that means is OCD is twice as common as schizophrenia. A second misconception is that OCD starts in adulthood. Well, the facts are half of OCD cases start by the age of 19. That's what median means. Half of the cases before 19, half of the cases after. And a quarter of the cases, the onset of OCD is in those 14 years or younger. So I just want to really emphasize that for the child providers out there who are listening, the importance of looking for OCD in your children and adolescents. The other thing that's really important about OCD is that the typical course is chronic, with waxing and waning symptoms. So what that means is if you get OCD in childhood or adolescence, you're likely to have it the rest of your life. The third misconception is that OCD is all about washing and checking. So let's talk about the hallmarks of OCD. So the hallmarks of OCD are in its name. To have OCD, you need to have obsessions and compulsions. And what are obsessions? Obsessions are often repetitive thoughts, but they can also be intrusive images or urges or impulses, and I'll give you examples in a minute. The other hallmark of OCD are compulsions. And what are compulsions? They're repetitive behaviors or mental acts that someone is driven to do to reduce distress or prevent a feared outcome. Now, what do I mean by mental acts? I mean mental rituals that someone goes over again and again in their head. And again, I'm about to give you some more specific examples. Now, the key point is that the vast majority of people with OCD have obsessions and compulsions. So even though in our Diagnostic Statistical Manual, DSM-5, it says and or, more than that, when we do studies on people with OCD, 95% of people or more have both together. But the key thing is that the content varies. Now, what do I mean by that? So there's a big range of types of obsessions people with OCD can have, and a big range of different types of compulsions people with OCD have. And these have been and so yes, washing and checking can be symptoms of OCD, but there are many, 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 many symptoms. And these have been grouped by investigators into 5 what have been called symptom dimensions. So one, for example, is contamination with washing or cleaning. So for example, I've worked with a woman who was really afraid of catching AIDS, HIV disease, and so she would be washing herself all the time. That would be an example of a person with OCD who had contamination and washing concerns. But there are thousands of different versions of contamination and washing concerns. A second big domain of concerns that people with OCD can have are concerns about harm, either befalling themselves or befalling someone else, or they're harming someone else. And these are often coupled with checking rituals. So to give you an example of this, I worked with a man who was worried about causing harm to others. And so when he drove around New York City, for example, he couldn't make it easily through traffic intersections because every time he went through a traffic intersection, he'd get the intrusive thought that maybe he'd run someone over, and he'd go back around and around and around the block, making him often late hours at work because he was constantly checking. Another example of OCD is concerns with symmetry and exactness and ordering. And an example here would be I worked with someone who everything had to be exactly lined up and symmetrical. So when I went to her closet, for example, all the shirts were together in ordered sizes, in ordered colors. And it wasn't that she just liked it that way, she had to have it that way or it made her incredibly anxious. Another dimension of OCD are taboo thoughts, and these are typically of a sexual or religious nature, and these are often coupled with the mental rituals that I told you about. So, for example, I worked with a person who had intrusive thoughts about having sex with his mother or his child, and he would call up images in his mind and have lots of mental rituals to try to reassure himself that he wasn't actually going to act on these. I worked with someone who was an Orthodox Jewish man who had the intrusive thoughts of maybe Jesus Christ was right. So those are examples of taboo thoughts that were highly distressing to these people that led to many rituals to try to reassure themselves that they weren't really going to act on these taboo thoughts. And finally, hoarding behaviors are a dimension that's been found in OCD. Now this is a little tricky because some people who used to be thought to have OCD now would be diagnosed as hoarding disorder. And what I mean by that is they really have nothing but hoarding behaviors, excess accumulation of things and inability to discard things. But there are people with OCD who keep things, hoard things, for an OCD concern. For example, I had a woman who had hoarded newspapers, and specifically the Scientific Times that describes medical information, and her intrusive fear was that if she threw it out and someone in her family needed it, she'd be responsible for their harm. So all of what I've just described for you are examples of different domains of content that people with OCD can have, and it's important to know that many OCD patients have obsessions and compulsions in multiple of these domains, but it's helpful, I think, to get a flavor of the range of the disorder. So no, OCD is not just about washing and checking. Let's go on to the fourth misconception, and this one I hear a lot, and this one bugs me a lot, which is there's a lot of joking about when people hear what I do. A common thing that people say to me is, "Oh, come on, everyone has a little OCD." Well, no, we don't all have a little OCD. So to have OCD, it's a disorder. The symptoms must occupy at least an hour a day, and many of the patients that I work with are obsessing and compulsing 3, 5, 8 hours a day or all day long. They're never free of it. The symptoms must be significantly distressing, and what's really important is that it causes significant impairment in functioning. So that's one important point, is that the symptoms have to be severe enough and take enough of someone's time, which really can interfere with their functioning. In addition, that when people have OCD, epidemiological studies have shown that the vast majority of them have moderate to severe symptoms. So this is not a little bit of OCD stuff. When you have OCD, you're ill and it's serious. Now, it's important about now to emphasize what's not OCD. So all of us will have intrusive, studies in healthy human beings will show that all of us will have the occasional intrusive thought or maybe a repetitive behavior. So for example, if you've ever gone to the airport and checked more than once that you have your airplane ticket, there's an example of a little repetitive behavior triggered by anxiety. Again, that's not OCD. That's something that's a fleeting thing you easily dismiss. OCD is a bad, disabling disorder. Let me move on to the fifth misconception, which is that all repetitive behaviors are OCD. Well, there are lots of repetitive behaviors that are attached to different types of disorders, and they're not OCD. So, for example, think about the person with generalized anxiety disorder who worries all the time. Think about the person with major depressive disorder who ruminates over things that they've done in the past over and over again. Think about the person with trichotillomania or hair pulling or skin picking. These are body-focused repetitive behaviors. Or think about the person who's got maladaptive perfectionism and has very rigid habits for how they like to do things. That's the person with obsessive compulsive personality disorder. Or think about the intrusive flashbacks that someone with post-traumatic stress disorder can have. All of those can be described as intrusive thoughts or repetitive behaviors, but those are not OCD. Now, having said that, can you have OCD and any of the disorders on this list? Of course you can. It's also true that OCD commonly occurs with other disorders. So the most common comorbidity in OCD are other anxiety disorders, social anxiety, specific phobias, generalized anxiety disorder, and panic disorder. Another really common comorbid disorder with OCD is depression. OCPD also is comorbid with OCD, but it's comorbid with many other disorders as well. And finally, there seems to be sort of a constellation of attention deficit hyperactivity disorder and tic disorders, particularly in children. The other thing I really like to emphasize, particularly for those of you out there who are working with people with psychotic disorders, up to 25% of those with psychotic disorders, schizoaffective disorder or schizophrenia, will have obsessive-compulsive symptoms or indeed meet full criteria for OCD. And the important thing to know is this is a complex relationship. Sometimes obsessive-compulsive symptoms precede a first-break psychosis. Sometimes psychosis is exactly comorbid with OCD. Sometimes the drugs that we use to treat psychosis, antipsychotic medications, can trigger OCD symptoms. And then finally, you can have OCD all on its own, and it can be pretty bad. And in fact, people can be delusional about their symptoms. So it's a complex panoply, but I just want to highlight anybody who's seeing people with psychotic disorders, please keep a lookout for OCD symptoms. The sixth misconception is that OCD is all in your head, and obviously this is a common sort of thing that people say about many of our psychiatric disorders. Now this is a funny one because in fact OCD has been associated with brain abnormalities. So if you will, in that sense, it is in your head, but it isn't all in your head because the key question is, well, what causes those brain abnormalities that we can find in people with OCD compared with people who don't on brain imaging studies? And we don't really know the answer to this, like we don't know the answer for many of our psychiatric disorders, a reaction that could cause OCD. And finally, there's new onset cases of OCD after specific neurological insults, for example, a stroke in the particular circuits that have been implicated in OCD. But I also want to emphasize that OCD is not just a biological disorder. Environmental factors, particularly trauma and stress, have also been implicated, whether there's a cause of it or whether they're what brings out the risk. A lot of people are studying these issues as we speak. And the final misconception that I want to emphasize is this one, is that OCD is untreatable. And certainly when I started in the field, OCD was seen as untreatable. But in fact, it's really not the case anymore. So here are the facts. There are two proven treatments for OCD, and these are recommended in practice guidelines, in fact, all around the world. One type of treatment is treatment with medication. They're called serotonin reuptake inhibitors, and they include the medication called clomipramine, which is a tricyclic antidepressant, as well as the selective serotonin reuptake inhibitors, and those are medications like fluoxetine, paroxetine, sertraline, fluvoxamine. Now, the key thing about medication treatment in OCD, these are medications that we often use for depression, but in OCD we use higher doses typically than we use for depression, and we usually wait 6, 8, 10, 12 weeks to see the full effect. The other key thing about treatment with medications for OCD is the medications typically reduce symptoms, but don't take them all away. So the key that you're looking for is not that you give them a medication and 12 weeks later they're cured. What you're looking for is you give them the medication and 12 weeks later they've had a 20 to 40% drop in their symptoms. And that's great. If you've been obsessing and compulsing 8 hours a day and your symptoms drop to 4 hours a day, that's the glass is half full. But you can see the glass is still half empty with our medications. You still have symptoms most of the time. That's where the other treatment becomes so important. So the other treatment we have for OCD is cognitive behavioral therapy. Now, cognitive behavioral therapy is a great big umbrella term. Some cognitive behavioral therapies are more cognitive, some are more behavioral. The one that's been particularly studied in OCD and has the strongest evidence base is one that's more behaviorally oriented, and it's called exposure and response or exposure and ritual prevention. Now, what does it mean to do exposure and response prevention with someone with OCD? What you do is you take someone and you really understand their symptoms, all the things that trigger their obsessions, all the different rituals they're doing. Let me take an example of someone with contamination fears and washing rituals. You then make a hierarchy of the triggers that they're most afraid of. So in that woman with AIDS, I wouldn't start with, a test tube of blood. You might start just by, how does she feel about touching door handles and maybe the carpet in my office? So that's a hierarchy of triggers and exposures. And then you're coaching her how not to do her rituals, to break that habit that she's developed between the triggers leading to the rituals. It's a very intense treatment, but it's done usually in 15 to 20 sessions, and the effects can be really quite remarkable in those who can adhere to the treatment. So we wanted to give you an example to bring it home, give you a real person who's obviously, a compilation of different cases to protect the person's privacy. So let's meet Jimmy, who's a 43-year-old teacher with a family history of anxiety. Now, as a child, Jimmy worried about bad things happening to his family. He spent a lot of time in his homework, which his mother and father thought was great. This was a kid who was getting his homework done. But in fact, he was worrying a lot about whether he was doing it correctly. And his fear about harming led to social avoidance. The spending so much time in his homework and fearing that he was going to do it wrong led to late assignments. And he had real difficulty finishing exams in high school. But no one really thought about, they just thought he was sort of an anxious kid. No one really thought about OCD. And it wasn't until he got to college and started to fail out of college because of his OCD symptoms, and he went to the college mental health, that someone diagnosed him with OCD and finally started him on serotonin reuptake inhibitors, again, one of our first-line treatments for OCD. He tolerated the medication very well. It dropped his symptoms, and he went on into his life. He became a teacher. He performed relatively well at work for many years, and he felt that while he still had symptoms, his symptoms were manageable. But then what happened? In the last year, his father was hospitalized with pneumonia. And now Jimmy was really triggered by going to the hospital and seeing, really sick patients in the hospital, as well as seeing his father sick. And he started to obsess that he might contaminate his father and cause his death. So luckily, he was because he was on his serotonin reuptake inhibitors, he was under treatment with his psychiatrist. And the psychiatrist knew about the data, about the powerful effects of cognitive behavioral therapy consisting of exposure and ritual prevention for OCD, and knew that, in fact, it could work on its own or also work when added to the medication. So the psychiatrist not only increased the SRI dose, but also referred him to a course of therapy. This really caused Jimmy to perform, really get his symptoms under control. It gave him a set of tools that he could use on his own. And the good news is it enabled him to go visit his father, and his father did well in the hospital and is, doing well to this day. So just the take-home points, just to emphasize some of the teaching points I've tried to make along the way. OCD commonly can occur in childhood and adolescence, but the diagnosis is often missed, as it was in Jimmy. People can experience different types of symptoms over time. Jimmy was more concerned with harm as a kid. It looked more like contamination concerns when he was an adult, but you can see the theme of harm is still there. The third point is that OCD can disrupt functioning in many different ways depending on the age of the person and what they're doing in their life. So, for example, Jimmy, as a child, was having trouble with schoolwork. As an adult, was working well, but then was having trouble functioning socially in a way he needed to function in his life when his father got ill. And finally, again, those two proven first-line treatments, both medications and this very powerful cognitive behavioral therapy. So the bottom line, remember, OCD is more common than schizophrenia, so it is out there, but you often have to look for it. And it's important to look, because if you find it and detect it, you've got treatments where you can help up to half of people become well.
So with that, I'd like to conclude with some acknowledgments of our collaborators in this effort, all from the New York State Office of Mental Health, the Center for OCD and Related Disorders, the CPI, as well as our Provider Advisory Committee. These are folks who have generously taken their time out and provided us with valuable feedback about how to develop and move forward with our goals for this workforce development program. We have some references for many of the research-related statistics and information that we've provided throughout this webinar. And I'd just like to thank you all. On behalf of Dr. Simpson and myself, we really appreciate you joining us this afternoon. We hope that you've taken away some information that will help you start to address OCD within your communities, and we look forward to continuing to work with you and help address some of the needs that you all have within the community in working with folks with OCD. So thank you very much, and have a lovely afternoon.